Muy buenas tardes a todos los que nos acompañan desde Latinoamérica. Un saludo muy especial a los que nos ven por diferido. Hoy, nuestra última clase con la doctora Elizabeth Domínguez, no podríamos cerrar de mejor manera este curso. Y hablando de patologías isquémicas y traumáticas por tomografía y resonancia en la columna. Muy buenas tardes, noches para usted, doctora, ¿cómo está?
Hello? Yeah, I'm visible now. Okay, thank you very much. Thank you for the introduction. So if you're ready, we're gonna start with the lecture. That's the last one. Let me see if it works. Okay, so can you see my screen now?
Yes.
Okay, so excellent. So this is the last lecture, and it will cover two topics that are can be related, but they are also very different. One is the presence of ischemic lesions in the spinal cord, and the other is the traumatic diseases of the vertebral column and involvement of the spinal cord. So we will start first with the description, or what can we see with ischemic myelopathy, because it's a subject that is a little bit shorter. And basically, I will give some introduction, and then we will see a lot of examples today. So we will see a lot of images in this lecture. For ischemic myelopathy, it is always useful to remember the anatomy of the spinal cord and then the vascularization of the spinal cord. This diagram is also taken from the MRI book of Dr. May. It is really helpful. So the arterial supply to the spinal cord is mainly based or divided depending on the region of the vertebral column. For the cervical region, the main arterial supply comes from the vertebral arteries. From the thoracic region, it's supply from the intercostal arteries. And then we have the lumbar arteries in the lumbar region and the sacral arteries in the sacrum. From these major vessels, we will have some vertebral branches that will enter the vertebral canal through the intravertebral foramina. Those branches will enter the dura mater and will divide into ventral radicular arteries and then some smaller dorsal radicular arteries that will give or mainly irrigate the nerve roots. Okay, so from that level, we will go a little bit deeper and deeper to obtain little branches that will irrigate the spinal cord parenchyma. So what's ischemic myelopathy? When we have an occlusion of the intraparenchymal spinal cord arteries, so little arteries that irrigate the spinal cord parenchyma, this may result in an ischemic damage to the spinal cord. We have in dogs and cats two main reasons for that. The first one, which is the most common in dogs, will be the embolization of fibrocartilaginous material, which is known as fibrocartilaginous embolism. And in that case, what happens is that we have an embolus that is made of material that is histologically and histochemically identical to the nucleus pulposus of the intervertebral disc. We know that because we have some histopathological studies assessing these dogs with a ischemic myelopathy, and this material is visible inside the spinal cord, but we don't know the source and the pathway into the vasculature. So this is still unclear. There are several theories, but we don't know what happens exactly for some material that is exactly the same as the nucleus pulposus to enter the vessels and cause this type of ischemic lesion. And then the other type of lesions that may result in ischemic myelopathy are also the presence of thrombi from bacterial, parasitic, neoplastic origin, and also we can see some neoplastic emboli. So those are the main causes for ischemic myelopathy in dogs and cats, and with a special consideration in dogs for fibrocartilaginous embolism. We need to know also that it is always important or relevant to remember that there are some medical conditions that will be predisposing factors leading to embolization or thrombosis in the body. So those are the typical ones that we know already from the brain. Animals with cardiomyopathies, hypothyroidism, hyperadrenocorticism, renal disease, systemic hypertension. Regarding ischemic myelopathy, what we know is that the changes that we can see in the spinal cord, in the lesion in the spinal cord, are non-specific for the underlying cause of this disease. So we will see a lesion in the spinal cord, but it's not possible based only on imaging to know if that was caused because of a fibrocartilaginous embolism, or if it is caused because of secondary, for example, from a neoplastic emboli. Okay, the imaging is non-specific for the underlying cause of the event. These lesions, in theory, or what we know until now, is that they are more common. I think that's true. They are more common in dogs than in cats, and it usually affects middle-aged dogs. But they can be, so these lesions can be visible in dogs that are also very young. So the most common is a presentation of middle-aged dogs, but it is not specific for this range of age. You can see it from very young dogs to old dogs. And it is also more frequent enlarged to giant non-chondrodystrophic dogs. The clinical presentation is really important in those cases because it will help in the differential diagnosis, because typically what we see in dogs and in cats is that they are presented with a hyperacute onset of non-progressive, non-painful in many cases, symmetric or asymmetric motor dysfunction. So this is the most typical and classic presentation. Okay, there are maybe some small differences in some animals, but it's usually hyperacute, non-progressive, and non-painful. And the owners or family of the animals frequently report that this has happened after exercise or a minor trauma. The clinical presentation is very similar to other conditions that we have seen before, like acute non-compressive nucleus pulposus extrusion, but then the etiology of the lesion is different, and the changes that we can see on MRI are also very different. In dogs, you see usually these conditions more frequently in the lumbosacral and the cervicothoracic region, and it's less common in the thoracolumbar region, but it can also happen. And what happens in cats? In cats, it is more common to have a cervical localization. And in cats, we have also some information that says that this kind of ischemic myelopathy is commonly associated with hyaline degeneration of the ventral spinal artery, basilar artery, or in the branches of these vessels. The imaging modality for ischemic myelopathy in this case will be MRI, and this is mainly because the lesion will be intramedullary. That means that if we want to see the ischemic lesion, we can be more successful with MRI compared with other techniques. Okay, so we can do a CT, and maybe in these animals with this clinical history that is very supportive of an ischemic event, we can do a CT to exclude other causes of an acute onset of clinical signs, like an acute disc extrusion or other things like that. But it will be very difficult or complex to see particularly the specific lesion in the spinal cord, okay? We can do a myelocity, and we can also assess or see some changes that may suggest that we have a focal intramedullary lesion with attenuation of the contrast in the subarachnoid space. But again, seeing the proper lesion in the parenchyma is complex. And regarding MRI, something that is also very important is to remember that even using MRI, the MRI can be normal. So we may have a dog that was completely normal 2 hours ago and suddenly is paraplegic or paraparetic, and it was an acute onset, non-painful, and doesn't seem to be progressive. We scan the animal, we do an MRI, and the MRI is completely normal. Also, the presence of absence of lesions on MRI does not exclude the presence of an ischemic myelopathy in a patient that has clinical signs that are suggestive of ischemic myelopathy. And this is more common if we perform the MRI in the early hours after the event. So usually it says that if you perform the study mainly during the first 1-2 days, you have more chances to have like a normal MRI. But over time, the changes are more evident. If you do an MRI and the lesion is visible, what we see is, in most of the cases, is that we will have an intramedullary lesion that is intramedullary, that we don't see in most of the cases other abnormalities outside from the spinal cord parenchyma. And that lesion usually extends over several vertebral bodies. It is not typically located immediately dorsal to an intervertebral disc space. It usually is larger and it extends over several vertebral bodies. There are reports that says that in most of the cases, you will see that lesion close to a degenerated intervertebral disc, but this is not true for all the cases. And as I said before, the spinal cord changes are not usually centered above or directly over our disc space. These lesions are usually focal, and because they are ischemic, they are relatively sharply marginated, and they will predominantly affect the gray matter that is more sensitive to ischemia. However, sometimes we will see that the changes may affect gray matter and white matter at the same time. In most of the cases, the lesions are also lateralized, and the clinical signs will be also lateralized and therefore asymmetric. But we have some dogs that may show a more symmetric clinical presentation and more symmetric lesions. We can see some swelling or enlargement of the spinal cord due to edema that is usually present in the acute phases. And then the signal intensity of the intramedullary lesion is typically T2 and flare hyperintense to the normal spinal cord parenchyma. It can be iso to hypointense on T1. For example, if we have more edema, it can be more hypointense. But if we have also associated intramedullary hemorrhage, we could see also some T1 hyperintense foci inside the spinal cord. And we can see heterogeneous post-contrast enhancement, which is more common after 5-7 days of the ischemic event. And it's also very useful to remember that we can run additional sequences to detect hemorrhage, such as gradient echo, or to detect ischemia, such as diffusion-weighted imaging and ADC maps, if they are available in our machine. So we will see a couple of cases. The first one is a dog, that's a Schnauzer, 2.5-year-old. And we are seeing here a dorsal T2 and a dorsal star sequence. We are at the level of the thoracolumbar region. This is cranial, this is caudal, and we are here at the level of T13. And we see that the yellow arrows are pointing to an intramedullary lesion that more cranially, it is slightly lateralized towards the left of the animal, and more caudally, it involves more the right and left sides of the animal. And that lesion is hyperintense on T2 and on STER compared to the normal gray matter. So now we'll see the comparison of this lesion on the sagittal and the transverse planes. Here we are more or less located at the level of T12. And we see that this lesion is visible at least from T11 to L2 in that case. And the lesion is pretty extensive. In that case, we don't see any degenerated intervertebral disc space under or at this location. And there's a little bit, if we look at here, there's a little bit of attenuation of the, or thinning of the dorsal subarachnoid space along this lesion. If we look at it on the transverse plane, this is a T2 and this is a gradient echo on the right side. In the gradient echo, the lesion is visible, but it's hyperintense, so it's not showing any signal voids suggestive of hemorrhage. And on the T2 sequence, we can see that the lesion is pretty well demarcated. It has like a triangular shape and is hyperintense to the spinal cord. If we move more caudally, we see again the same lesion on T2. This is at the level of L1, and that's the level of L2. And the lesion again is a little bit, is well demarcated. It has more like well-defined margins, and is affecting, in this case, both the gray and white matter. So as a summary, we have like this extensive intramedullary lesion that was affecting our 5 vertebrae length. Is well defined. It was hyperintense to the normal gray matter on T2. And in this case, I didn't show you, but it didn't have any post-contrast enhancement. It was mainly involved in the gray matter, but also the white matter. And there was a little bit of a spinal cord widening and swelling, but we couldn't see any degenerated intervertebral disc close to this lesion. Okay, so that's an example, a typical or classic example of a ischemic myelopathy in a dog. Then we will see that cat. This is a pretty young cat that had a 3-year-old cat. That cat was had a cardiac disease that was congenital, and it had also multiple malformations in the thoracic and in the pelvic limbs. Okay, so had an acute clinical presentation of a non-ambulatory tetraparesis that was a little bit lateralized towards the right side and non-progressive. Again, we have here the dorsal T2 and the dorsal stair, and we are more or less at the level of the cervicothoracic region. And again, we can see pointed with the green arrows that we have this intramedullary lesion that is extensive and is hyperintense to the normal spinal cord if we compare with the more cranial segment. And it is kind of central but lateralized towards the right side. Looking at the transverse and sagittal plane, so here we have on the left side the sagittal plane on T2, and then we will move from cranial to a mid portion and more caudal portion. And you see on T2 that we have this well-defined intramedullary lesion that is hyperintense compared to the normal gray matter. And it is, for example, in this level, we can see very well that it's affecting mainly the gray matter, so the central part of the spinal cord. In this case, it is at the level of T3, it is involving the left side and the right side, but as we move more caudally, it is more lateralized towards the right side. So again, it's a lesion that has the typical imaging features of of ischemic myelopathy. We have, based on MRI, some prognostic factors that we know for unsuccessful outcome, unfortunately. So we know that some patients that present at the time of presentation, they have a severe neurological score, they have more probabilities to have an unsuccessful outcome, which means that they don't recover from that lesion. And then using MRI, we can also compare the extension of the intramedullary lesions in an MRI, both the extension in a sagittal plane and also the cross-sectional area of the lesion of the spinal cord that is affected. And what we know is that if the length of the lesion is more than 2 vertebrae, or if the cross-sectional area of the spinal cord that is affected is more than 67% of the cross-sectional area of the spinal cord, these animals have more probability to have an unsuccessful outcome. And something also that is very important and has been related with an poor prognosis is the presence of intramedullary or extramedullary hemorrhage associated with these lesions, because it suggests the presence of intramedullary hemorrhage that the spinal cord had like a severe damage in the parenchyma, and it may be associated with the development of secondary myelomalacia. So that's basically like a very short summary of the typical appearance of ischemic myelopathy in dogs and in cats. Then we'll move now to traumatic injuries of the spine or the vertebral column. And that's a different subject, so the etiology is completely different. But the clinical presentation will be also very suggestive, so we will know that the animal had a trauma, and so they are presented because with a history of recent trauma. But in some cases, we will see also in the last case, we can see also some animals that have like chronic conditions that are secondary to a previous or an old traumatic event. Okay, and we can also see some changes on CT and MRI. So for traumatic injuries to the vertebral column that are acute, what happens is that because of the acute trauma, the vertebral columns may suffer instability. And because the vertebral column is not stable anymore, this may damage secondarily to the spinal cord and or the spinal nerves. And as a result of that damage to the nervous system, we may see the clinical signs in the patient. What can happen in the spinal cord? It may suffer from contusions, compressions, or lacerations secondary to the trauma. In this case, in traumatic injuries of the spine, CT is still considered the gold standard in the evaluation of spinal trauma. Why? Because it's very useful for the diagnosis and for surgical planning of these cases. then it is also very interesting because the patients can be sedated. So the scan can be done with the patient under sedation or under general anesthesia. And the scans are usually quite kind of quick or fast. And also it is very helpful because CT is superior to radiographs. So if we have to if we compare CT with radiographs, CT will be always superior to radiographs in the assessment of vertebral fractures. If we don't have a CT, we only have a radiographs. We know that radiographs have a low sensitivity to diagnose vertebral fractures and vertebral subluxations and or instability, unfortunately. And then the other thing is that in general, radiographs are not useful in the evaluation for compressive lesions or to see damage to the spinal cord or to the spinal nerves. And regarding MRI, MRI in veterinary medicine is poorly described still in the evaluation of vertebral trauma. However, there are some studies, and in the clinics we use MRI in the assessment of these animals. It is specifically very useful in the evaluation of the spinal cord and in all the soft tissues that may be damaged during the trauma. And it can be also very useful in the assessment of for a prognosis of the lesions and surgical planning. Okay, so ideally, in a perfect world, and to obtain a maximum benefit of all the techniques, a combination of CT and MRI will be excellent to assess everything because it will allow us to assess all the osseous structures and all the soft tissues. However, as we know, this is not always possible because of different reasons. Sometimes the two machines are not available in the same planes. Sometimes the animals are not stable to be under two different studies, and then there are other times that it's just because of an economic limitation. But if we wanted to assess everything, that would be the best option at the moment. There are some studies that have compared the MRI and CT, their agreement in the evaluation of vertebral fractures in dogs with trauma. That was published some years ago, 7 years ago. Wow, that was, wow, time flies, yeah. So that was published 7 years ago, and in this study, the authors did a complete evaluation, and they compared the evaluation of CT and MRI in dogs that had trauma and to see if there was a good or bad correlation. And the results of this study were a little bit, unfortunately, they were not very good because what they saw was that MRI, although it is useful to detect the presence of fractures, at the moment and with the knowledge that we have, it's not able to replace CT for a complete evaluation of the traumatic injuries in the vertebral column. Of course, it can be also, we need to understand that there's some limitations and some things that may result in a poor correlation is that, of course, evaluating MRI is less direct, and we may need more experience to see the lesions. They are visible, but you may need more experience with the technique to be able to assess or to see the lesions. And of course, it has not the same type of detail as a CT compared to for the assessment of the osseous structure. So at the moment, we can't replace CT with MRI. Okay, so in the assessment of vertebral fractures, or when we have a trauma in the vertebral column, something that is kind of common is that we may have some fractures or some subluxation of the vertebral column. And when we assess the fractures in the vertebrae, we will use more or less the same approach that we have to assess fractures in the long bones. So we will assess the alignment of the vertebrae. We will assess also we will try to describe the type of fractures, if they are transverse, if they are oblique, if they are compression fractures, comminuted fractures, the degree of displacement, and all the same things that we use for long bones. But on top of that, when we are describing vertebral fractures, there is something that we need to add in our report, and is how many compartments of the vertebral column are affected. So there's a theory that is the three-compartment model that says that divides the vertebral column in three different places: a dorsal, a middle, and a ventral compartment. And the theory says that a traumatic lesion that results in that involves two or more of these compartments, so two or three of these compartments, will be unstable. And that suggests then for the surgeons or for the neurologists that if this lesion is unstable, they may think, or they may have to think, in stabilization of the vertebral column. Of course, there are some, this is not always true, but it's a good model to follow to try to understand if the patient will need stabilization or not. So we need to know about it. So we have the vertebra that is divided in three compartments. The dorsal compartment contains the vertebral arch and the dorsal ligamentous complex. And inside the vertebral arch, we have the lamina, spinous processes, articular processes, and the pedicles. And for the dorsal ligamentous complex, we have the capsules of the articular processes joints, and then several ligaments, interarcuate, interspinous, supraspinous, and intertransverse ligaments. For the middle compartment, that is a little bit more ventral, we have the dorsal longitudinal ligament, the dorsal part of the annulus fibrosus, and the dorsal part of the vertebral body. And finally, the ventral compartment includes the remaining of the vertebral body, the ventral and lateral surfaces of the annulus fibrosus of the disc, the nucleus pulposus, so the central part of the disc, and the ventral longitudinal ligament. So if you don't remember very well the anatomy, there's a picture in here, and we have also a reference of this paper that talks a little bit in general about vertebral fractures in small animals. And then this other paper that is from 2012 that describes this theory or model of three compartments in animals, in dogs that have vertebral trauma. So as I mentioned before, sorry, if we're seeing here vertebrae in transverse plane, the dorsal compartment will be on the top, the middle compartment in the middle, and then the ventral compartment at the bottom. Dorsally, we have this part of the arch, the spinous processes, the lamina, the pedicles, then also all the ligaments that live in that area. The middle compartment that is here in the middle will have the dorsal longitudinal ligament, the dorsal part of the annulus, and the dorsal part of the vertebrae. And then the ventral part is the part that contains the rest of the vertebral body, the lateral and the ventral surfaces of the annulus fibrosus and the nucleus pulposus, and also the ventral longitudinal ligament that is not shown in this picture. So that's more or less the three compartments. And in theory, if you have involvement of two or three, it means that it's unstable. So this is something that you should add in your reports. Okay, so now going to more practical tips. When we are in front of an animal that had a suspected trauma or a history of trauma, and we will need to do imaging studies, the first thing is to remember that the patient is always first. So it is really important to have the animals that are stable enough to be able to undergo the imaging study. It is not worth to lose a patient in a CT scanner or an MRI just to obtain some images. And because the patient is first, in many cases when we have a traumatic injury in a dog, it won't be possible to put the animal in dorsal decubitus. We know that for spinal CT and MRI, the most optimal position of the dog will be in dorsal the recumbency to avoid any motion. But in those cases, when they have like a trauma and we suspect that there may be some instability, the animals in most of the cases will be positioned on lateral decubitus or in sternal decubitus if they are in that position. Then if we are doing an MRI, something that is also very useful is starting with a dorsal plane that will be like a ventrodorsal radiograph with a large field of view and with STER sequences, because STER will show you the changes in the soft tissues very easily. So it will point out where the soft tissues are abnormal, and if they are abnormal, is probably the place where there was the most of the trauma, and we can pay more attention to the vertebral column at that level. So for vertebral fractures, as I mentioned before, we can look for the presence of to the alignment of the vertebrae. We can also assess if the cortex of the vertebra is continuous or if there's any discontinuity. If there are changes in the contour in the vertebral length, that this is very important for compression fractures, that in compression fractures, they are reduced in length or they look smaller, the vertebrae. We can also assess the attenuation on CT or the signal intensity in MRI of the bone marrow, because it may suggest the presence of hemorrhage or edema. The fracture lines on MRI, if we are looking on T2 or on gradient echo, can be seen as hypo-intense lesions, so black lesions, because of the presence of hemorrhage. And if we have any spinal cord edema, contusion, it will be T2 or STER hyperintense compared to the normal gray matter. Then, if we want to be sure if there's any vertebral subluxation, I will strongly recommend you to assess the alignment of the vertebral column in different planes, not only on the sagittal plane. Why? Because sometimes on the sagittal plane, everything looks very well aligned. And then when you look at the dorsal plane, there's some subluxation on the lateral direction, okay? And then it is also very useful to look in the transverse plane, because we can see widening of the articular processes joints that are joints that should have a specific size or width. And when there's a subluxation, because of the displacement of the vertebrae, they become wider than normal. And finally, MRI, because of the ability it has to show lesions in the soft tissues, is really helpful to point you like, hey, I have a lesion here, because there are changes in the soft tissues, in the muscles or in the disc itself, changes in the intervertebral discs, and so on. Something that also we need to remember, and it's something that we see a lot with MRI, is that when dogs or cats suffer from a traumatic event, it is not uncommon to have traumatic disc extrusions. Okay, so a disc that was normal, an intervertebral, suddenly, because it has this trauma, it may become extruded, have a disc herniation. So we need to pay attention to the intervertebral discs, because they can be distorted with in abnormal width. They can be narrow or wider than normal. And also we can see changes in the signal intensity of the discs itself. In many cases, when we have an intervertebral disc herniation that is traumatic, the most common ones are acute non-compressive nucleus pulposus extrusion. So discs that were normal, but because of the trauma, there was an acute extrusion of the nucleus pulposus with that secondary spinal cord contusion. But in some cases, also some discs that are degenerated, so that were generated before the trauma, when they suffer the trauma, they may become extruded, and that will be like an Hansen 1 disc herniation, but secondary to a disc, a traumatic event. So it's interesting to look at this. We need also to pay attention to the presence of hemorrhage. Remember that on CT, hemorrhage will look hyperattenuating compared to the normal soft tissues. And on MRI, we can see lesions that will be signal voids on gradient echo, or hyperintense lesions on T1 if they are acute. And if we see hemorrhage, that, remember also, that may suggest a worse prognosis for the animal. Inside the spinal cord, we can see lesions, mainly on MRI, and those lesions in human medicine, they are divided in 4 types. The spinal cord can be normal, it may show focal edema, sometimes we have like multifocal edema, or we can have also edema with hemorrhage, which is worse. So we will need to pay attention to all these things during our report, and also to describe and to look for these changes, because we can, it may suggest a poor prognosis. And finally, we can also look at all the muscles, because they will point out where the lesion or most of the lesions are. For another complication that is kind of difficult to diagnose with MRI. It has been described using mainly myelocity, is that in some cases we can see a rupture of the dura mater. And if we do a myelocity, obviously what we can see is that the contrast inside the subarachnoid space can have leakage outside of the subarachnoid space at the site of the rupture of the dura. And this is important because these animals may have some complications associated with a dural rupture, mainly because of herniation of the nervous tissue through the defect. Sometimes also it can be entrapped into a scar tissue and may cause chronic pain and neurological deficits. In human medicine, there's also descriptions of a continuous leakage of CSF through the defect, and it can also be it can have also an increased risk of infections and meningitis. So in all this, from here till the end, we will review different cases of animals that had had a traumatic injury to the vertebral column, and we will see different clinical presentations or different lesions, both with MRI or with CT. Okay. So this is mainly because, of course, a traumatic injury will be very different in every animal because it depends on the trauma. It's not like with ischemic myelopathy that it may follow a pattern. In these cases, we will see something that can be very variable depending on where the trauma was, the timing of the lesion, if it is acute, if it is chronic, if the animals have several lesions or a single lesion, etc. So that's a cat. That's a domestic short-haired cat that had a spinal trauma 4 days ago, and nowadays is paraplegic. And the neurolocalization of this lesion was T3L3. So that's a dorsal stern. We have the right side here, the left side here, and just with this plane, what we see is that there's a little bit of effusion here, abdominal effusion. So that's the liver, that's the stomach, this is the left kidney, and we will scroll now through the spine. We are going from from ventral to dorsal. So here is more or less at that level in the middle that we see that the vertebrae have a normal length, and we are seeing the intervertebral discs that have a uniform width, and they are hydrated. They have a normal signal intensity on T2. But as we move a little bit more cranial, here is more or less as the level of T13 because we see a rib and this is L1. We see that this intervertebral disc space has a reduced, is narrow, and the nucleus pulposus is a little bit smaller than normal. And then if we move more cranially, we see that this vertebra, this T13, is foreshortened, is shorter than the T12, and it has also an abnormal increased signal intensity. So we see that this is the normal signal intensity on the stern of the vertebra, and this one is a little bit shorter and has this hyperintensity. But in the cranial aspect, it has this area that is a little bit hypointense. And then we have also the associated changes in the width of the intervertebral disc. I'll move a little bit back. So that's normal spinal cord. And as we move more dorsally, we see the changes in the vertebrae. And if we move a little bit more, we see also that the spinal cord parenchyma is a little bit hyperintense. Good. So now we are going to compare to the sagittal planes. And that's a dorsal sagittal T2. And this one is a sagittal gradient echo. If we look at the sagittal T2, we can see that in the lumbar region, the alignment of the vertebra is normal. But as we're right here at the T12 and T13 vertebrae, the T13 vertebrae has this, is a little bit foreshortened, so it's a little bit shorter than the rest of the vertebra. And we see here in the cranial aspect that there's a black, a hypointense oblique line that runs through the cranial end plate of the vertebra. And dorsally, this vertebra shows a small step in the dorsal margin of the vertebral body. So we have a misalignment here of the vertebral canal. And at this level, if we compare dorsally, we see also that the arch is like ventrally located. So there's as a result of this, we have a dorsoventral narrowing of the vertebral canal, and we can see an associated intramedullary lesion that is pretty extensive on the T2 sequence, but there's no gradient echo signal void, so apparently there's no hemorrhage in it. And as I mentioned in the dorsal plane, if we compare the size of this nucleus pulposus of T13L1 with the caudal intervertebral disc space, we see that this nucleus pulposus is larger and this is reduced in volume, okay? So maybe something happened in here. So we'll move now in the transverse plane from the level of T12. And what we see is that the spinal cord on the transverse plane is a little bit swollen, and we have this kind of diffuse ill-defined intramedullary lesion. And we see also some changes in the paravertebral muscles that show a T2 hyperintensity. If we move a little bit more caudal and we are here at the level of the cranial aspect of the T13 vertebrae, where we have the fracture line, we see that there's a dorsoventral narrowing of the vertebral canal. We lose the visualization of the CSF and the epidural fat dorsal and ventral to the spinal cord, and the spinal cord is dorsoventrally flattened. So it's compressed in a dorsoventral plane and shows an intramedullary lesion, as I described before. Also, additionally, if we look at the dorsal plane, we see that here is the stomach, then we have the spleen, and we see a little bit of free fluid surrounding the spleen. So we can also assess the thorax and the abdomen, even if we are scanning the vertebral column. So that's more or less, we had in summary in this cat fracture in the T13 vertebral body with mild degree of subluxation and shortening of the vertebra and dorsovertebral compression of the spinal cord with an intramedullary lesion and effusion in the abdominal cavity. Next case is an example of a boxer that was a male 13-year-old, and that dog was a little bit unlucky because 2 months ago he had a slot, ventral slot at the C5, C6 intervertebral disc space because to treat some ambulatory tetraparesis associated with intervertebral disc extrusion. And he was treated surgically, but now the clinical presentation is more acute because it was hit by a car and it arrived at the hospital in a shift-Harrington posture with pain in the thoracic spine and interscapular region. So the clinical suspicion was a severe spinal trauma. So let's see the radiographs. We are here just in the cervical region because the dog had a slot previously, and we can see here at C5, C6 that the intervertebral disc space is a little bit narrow. That's at the level of the slot. And we have a little bit of new bone formation ventrally and a little bit of sclerosis of the adjacent end plates. Okay, so we did a scan at this level with the MRI because having recent surgery, there was the clinicians were worried that maybe because of the trauma, this side of the slot may have had some complications. And what we see here is that, of course, the intervertebral disc space is a little bit narrow and collapsed, secondary to the previous intervertebral disc disease and the slot. And here in the transverse plane, we can see very clearly the slot in the middle of the line of the slot going through the vertebral body. And we see also that this spinal cord shows no signs of compression, but there's a little bit of an intramedullary lesion that was present before. So this was present before the slot. It's not a new lesion. And here a little bit more caudal. So then we move to the thoracic spine. That was the lesion, the region where the dog had most of the clinical signs. It was showing pain in thoracic spine and interscapular region. And being a boxer, the only thing that we can see here is a little bit of multifocal spondylosis deformans, which is breaching in the caudal thoracic region and the thoracolumbar region. But from these radiographs, to be honest, we don't see a lot more. So we perform an MRI of this patient, and we can see something very similar to the previous cat. So at the level of T8 and T78 vertebrae, there's a misalignment of the vertebra. If you pay attention to the sagittal gradient echo, we see that there's a big step in the vertebral bodies. So T8 is ventrally displaced compared to T7, and this is visible at the level of the vertebral bodies, but also dorsally, or this spinous process is a little bit more, and the lamina is ventrally displaced. And of course, as a result of this displacement, we see a dorsoventral narrowing of the vertebral canal with compression of the spinal cord. If I go to the radiograph and we count 1, 2, 3, 4, 5, 6, 7, that's 7, that's T7 and T8, and we are not able to see this fracture here. So on the transverse plane, we have like a confirmation of this. This is more cranial, the block on the left. We are here at the level of T7, where there's a little bit of intramedullary lesion on T2. But then if we move at the site of the compression, we can see very clearly that there's a compression because of a dorsoventral stenosis of the vertebral canal due to the subluxation and the vertebral fracture. In this case, it was also possible to see some effusion in the abdomen and some pleural effusion in the thorax, and changes in the lungs that were probably due to collapse. Also, we can assess on a STIR particularly the changes in the paravertebral muscles, because of course, if we have a trauma in the spine, we will see also abnormalities in the muscles. And in this case, also more changes in the subscapular region, subscapular muscle, more cranially. Next case is another example of a dog that was hit by a car. And this case is a little bit younger, this animal. And in this case, we have a CT. So we will see the transverse CT, which is centered in the cervical region. And we will see the bone algorithm. Okay, so and we will move in from caudal to cranial. I'll pass it to see if you see any abnormalities. Good. So I'll move a little bit slowly. Here we're at the level of C2 vertebra. We're moving from caudal to cranial. And we see that there's an asymmetry in the vertebral body of C2. Okay, so we have this on the right side, there is this fracture line, which is, we have multiple fracture lines. So this is a comminuted fracture with the largest fragment being ventrally displaced. And in general, the vertebrae is a little bit dorsally displaced towards the vertebral canal. As we move more cranially, we can see more the multiple small bone fragments that are visible at this level, okay? In this study, it is really not possible to define with this algorithm if the spinal cord has any damage on it or not. And on the soft tissue algorithm, we couldn't see any visible or evident damage to the spinal cord. There was no evidence of intramedullary hemorrhage or extramedullary hemorrhage. So we had this fracture, comminuted fracture affecting the right lateral aspect of the cranial third of the vertebral body of C2, sorry. And it was also, the vertebra was a little bit dorsally displaced. So here we have some multiplanar reconstructions showing the multiple vertebral fragments. That dog undergo also MRI because we wanted to know, or the clinicians wanted to know if there were any other additional lesions, or to assess also the abnormalities in the spinal cord. And if we look here, this is C2, that's the dense of the axis. And we can see that this vertebrae has all this increased signal intensity and a stir that is secondary to the trauma and to some bone bruise or edema in the bone. And also something that we can pay attention is that, as I mentioned before, if we compare this intervertebral disc, that is C3, C4, we see that in this case, the intervertebral disc is completely normal in volume and in signal intensity. However, the intervertebral disc C2, C3 is a little bit narrower and the nucleus pulposus is reduced in size, okay? And then if we move more ventrally, and we are here centered at the level of the spinal cord, there is no evidence of a clear intramedullary lesion at the level of the fracture, okay? Good. We will see the same on transverse. Here we have a T2, a T1, and a gradient echo sequence. And we are moving from caudal to cranial. If we look again, we will see and pay attention to the gradient echo, which is pretty good to look at the bones. We can see here on the MRI as well the fracture on the right side of the vertebra that is also visible here. And we can also see that the spinal cord has no evident or intramedullary lesion, okay? And then when we move to the C2, C3 intervertebral disc space, we see that this nucleus pulposus is reduced and that there's a little bit of material, extradural material on the right ventral aspect of the vertebral canal that is causing a minimal dorsal displacement of the vertebral column, of the spinal cord, sorry. So here on the sagittal, we can see exactly the same. If we compare the size of this disc compared to the other, this one is reduced in volume. The nucleus pulposus is smaller, so it means that that one had a small extrusion of nucleus pulposus that is non-compressive. Okay, so let's see another case. That was an 11-year-old border collie that had fallen from a fourth floor. That was had a pneumothorax, hematuria, was paraplegic with deep pain positive, and pain in the thoracic spine. So that dog, we have a CT where we can see that it has multiple fractures in different vertebrae. So these are the most obvious. In T8 in the spinous process, but also presence in the cranial aspect, cranial end plate of T9. And then there were more fractures at other levels. We did the MRI because we see these fractures that are not, they don't look very unstable, but the dog was not doing very well. And in the MRI, what we can see is confirm the presence of the fracture in the spinous process, but we also see the presence of this intramedullary lesion between T8 and T9. And if we pay attention to the nucleus pulposus at this level is reduced in volume. And we can also see that the vertebral body of T9 is foreshortened and is a little bit increased in signal intensity, suggestive of a compression fracture. Another example is this dog that was hit by a car 7 days ago and was non-ambulatory with severe pain. And if we look at this dorsal scan in STAIR, we see already that there are a lot of changes in the caudal part of the lumbar vertebral column, mainly in the lumbosacral region. Okay, so here we have the most caudal part of the vertebral column. On the sagittal plane, what we see is that there's a displaced fracture at L7, which is kind of a moderate to severe ventral displacement that is involved in the vertebral body, but also arriving to the intervertebral disc space. There's a big step between the L7 and the sacrum, and we have some changes in the epidural space. We don't see very well the nerve roots of the cauda equina. So we're going to move from cranial to caudal in different sequences. Here we are at the level of L7, and we see all the changes in the paravertebral muscles. And as we move to the site of the fracture is visible here with a reduced volume of the nucleus pulposus. And then we will see a dorsal ventral narrowing of the vertebral canal with compression of the nerves of the cauda equina. That dog had other multiple fractures in the rest of the vertebral column that were less visible on the MRI. So we have a fracture at T7, T5, T8. And if we compare with the CT, and the CT is very easy to detect the fracture in the L7 vertebra with the lumbosacral subluxation. That was a comminuted fracture. And we can also see the loss of visualization of the normal epidural fat surrounding the vertebral, the spinal nerves. And with CT, of course, it is easier to see the multiple fractures that are in the rest of the thoracic spine. And the last case, and I put that case just because it's a little bit chronic, is a dog that had a poodle, 8-year-old, that had a chronic history of ataxia and non-ambulatory paraparesis. It was a rescue dog that when the family adopted it, it was already ataxic and non-ambulatory. And they decided to do some investigations to know what happened with the dog in the past. And what we saw was that at the level of T12, T13, there was like a chronic lesion with a severe narrowing of the intervertebral disc space that was already remodeled with some sclerosis, new formation, and some material that was probably the result of a fracture that was visible in the vertebral canal. And we know that this dog had a previous trauma because this is these are the articular processes joints, and we see that there's a widening of these joints. And there's a little bit of subluxation. T13 is a little bit ventral compared to T12. They did an MRI also to assess the spinal cord parenchyma, and we can see already that there's an intramedullary lesion here on T2. So just scrolling a little bit caudal from that level, we see that the lesion starts to be visible here in the center of the spinal cord, and then at the site of the previous fracture, there's a dorsoventral narrowing of the vertebral canal and a lot of new formation that is trying to stabilize this fracture, but they result in some compression of the spinal cord and intramedullary changes that can be just some degree of gliosis and atrophy because the changes are chronic. Okay, so that's also something that we can consider with some dogs that have chronic histories. And if we can see these changes, that may suggest that it had a previous trauma that was never treated, not stabilized, and is showing some chronic changes, which explain the clinical signs of the patient. So with this chronic and old case, we are finishing here. If you have any questions, I'll be happy to take them. If not, well, I will stop sharing my screen. And you tell me if there's any questions or not.
Perfecto, doctora, muchísimas gracias. Invito a todos aquellos que se encuentran conectados en la sesión en vivo a dejar todas sus preguntas en el chat o en la caja de comentarios. Y todos aquellos que vean esta conferencia en diferido, recuerden que pueden enviar sus preguntas al mail del diplomado, al número de WhatsApp, y nosotros enviaremos sus preguntas a la doctora. Así que voy a darles unos segundos para todos aquellos que tengan inquietudes. Y si no tenemos inquietudes en nuestra sesión en vivo de hoy, igualmente, muchísimas gracias, doctora Elizabeth. Para nosotros fue un gusto que nos acompañaras en todas
Welcome. Thank you
estas
very much.
conferencias, sobre todo hoy que es nuestra última charla en vivo con todos los ponentes, así que para nosotros es un gusto cerrar este programa contigo. Muchas gracias por todo.
Gracias and welcome. Muchísimas gracias.
Bueno, parece que no tenemos preguntas en esta sesión en vivo de hoy. Mira, el doctor Franco pregunta, ¿el Mielotac lo usa?
So right now where I work physically, we don't use it because we do, in general, what we do is a combination of CT, like CT, plain CT or intramedular or CT with intravenous contrast plus MRI. But in places where there's no MRI, they do sometimes myelocts in those cases, and we report them. So there's people who still use it, but I think that it's mainly if they don't have like a if they think that there's no an explanation for what they are seeing with the survey and angio CT, they may go to the myelocity. But if they got answers already with the survey CT and angio-CT, in many cases they don't do myelo-CT. I think it's something that is also like individual preferences. So yeah, personally, I don't use it because we go for the combination of the other two techniques. That for trauma, and for cases where the clinical history is really strongly suggestive of ischemic myelopathy, as I said before, like an acute onset of clinical signs with non-progressive changes, we go directly to MRI in those cases. Welcome.
Perdón. Perfecto, doctora. Muchísimas gracias. Esa fue toda nuestra conferencia del día de hoy. Muchas gracias nuevamente. Y para cerrar, los invito a nuestro próximo webinar totalmente gratis de ostectomía de mandíbula y maxila con piezo quirúrgico que se llevará a cabo la próxima semana a cargo del doctor Mauricio Austúa. Así que muchas gracias a todos por su compañía, muchas gracias por estar pendientes. Recuerden que estaré pendiente de recibir toda su documentación, su caso clínico y toda la información que hemos estado solicitando. Así que un gusto haberlos acompañado en esta experiencia y muy buenas tardes y muy buenas noches a todos. Nos vemos en una próxima oportunidad.